Hi there, it's Sarah here from BJC Health, and thanks so much for showing interest in watching one of our live events. So this upcoming event is facilitated by Dr Ilana Ginges. She's a rheumatologist here in Sydney, Australia. As we know that although rheumatic conditions affect both males and females, there are some conditions and some challenges that I guess are a little bit more specific to women. So we wanted to host an event where some of those challenges and perhaps some of those differences, we had the chance to talk about them, people ask questions. So I hope you enjoy the event. Leave a comment if you've got questions. If you like our stuff, then please consider joining BJC Connect. It's free, and that's where you can also access part 2 of this presentation. But enjoy. Hello everyone, good evening everybody. I'll just let everyone keep coming in and get their audio and get nice and comfy. So thank you so much for joining us tonight. Tonight's really exciting, I guess, for a number of reasons. So my name's Sarah, first of all, really looking forward to helping Ilana facilitate tonight's session. It's the first session we've run like this that's, I guess, specific to women's health. So that in itself, I guess, is a really special thing all in its own. And it's also the first event we're hosting with Ilana. She's 2 days down into working at, I guess, BJC Health Bondi Junction, which is very new. So her first couple of days were a little stressful. So we're grateful that she's here tonight. And so welcome to, I know we've got some people tonight joining who might have seen Ilana at Randwick, and this might be one of your first events associated with BJC. So a big welcome to all of you. Just a little bit of housekeeping before we get started. So typically for these events, you'll notice when you come in, you're on mute. And that's just so that when Ilana starts talking, you can hear her nice and clearly. We do love getting questions though. So there are going to be plenty of opportunities tonight where you can ask your questions, but we encourage you to use the chat. And so I'll be looking at that throughout tonight's event. Ilana will pause along the way, and we really want to hear from all of you, because I think tonight's topic, although Ilana's definitely going to be sharing some of her expertise, we think it's a topic where you can all learn from each other. And if there's things that you've tried that have worked, or if you see a question that you think you know the answer to, we love using the chat, as we feel that's a great way we can all learn from each other. So I think that's it. The session's recorded, so we typically put this on our platform tomorrow. So if you miss anything, we want to hear something again, the recording's made available. But other than that, I think that's everything. So otherwise, yeah, really excited to introduce Ilana. She's been brave enough to go, right, yep, we're talking about women's health and maybe some of the things that are a little bit trickier to talk about when you go to see a rheumatologist or a health professional. So over to you, Ilana.
Excellent. All right. Now I am going to share my screen. Sarah, is that working? You can. I'm so excited to welcome everybody to this talk. I can see already that we've got people from all over the gender spectrum. We've got young, we've got perhaps older, we've got people that are just starting out on their journey in rheumatology. We've got people who are experienced and wise and have probably experienced a lot of the things that I'm going to be talking about. I can hopefully help some of the other people. We're going to be talking about quite a few issues because, you know, if we think about women's issues in rheumatology, where do you start, right? So the obvious things that we often think about in medicine are the reproductive issues, and we do have quite a lot of knowledge about that. And that's things like family planning with contraception, pregnancy. We'll talk a bit about intimacy and the issues with that in people with rheumatological conditions, how our symptoms can change during the menstrual cycle. It's also important to talk about issues around menopause, understanding chronic pain in women. Interestingly, when I've spoken to women, I've said, what would you want to talk about when I do this webinar? And they've said the thing that most upsets them is perhaps changes in appearance, and can I talk about that? So that's something we'll talk about. Managing fatigue and the mental load that often comes with being a woman and parenting. And I'm going to throw it out to you as well, and hopefully you can write in the chat box, but what other issues do you think are more relevant for women who have arthritis or pain? And do you think we address those issues in our standard consults? How can we do better? I'd love to hear from you throughout this talk. We want to get better at this. And so we're asking you as the experts in your conditions and to come back to us and give us some ideas. So let's talk first about an overview. So we know that most rheumatic diseases are actually more common in women. So certainly rheumatoid arthritis, lupus, psoriatic arthritis is quite common in women. And of course, fibromyalgia, which some of you may experience, is certainly more common in women. We know that hormonal influences are very important. We know that activity of disease can change in pregnancy, in the early postpartum period, and in menopause. Issues affecting intimacy with men and women are important. These are important parts of our lives, but often we do neglect them in our medical consultations. And what I'm going to say is we need more research. So it's very clear when you look into this that things that affect women are not quite as well researched as things that affect men, and that's just how it is. So a lot of the issues that we're going to be discussing today, we may not actually have very good actual scientific rationale for, and that makes you the experts. We do need more research to understand some of these issues better. Let's talk about arthritis symptoms during the menstrual cycle. So a lot of patients will say to me, I seem to get so much worse around the time of my period. And there is evidence that symptoms of inflammatory arthritis and lupus may get worse just before and during the menstrual period. We think that the changes in hormones can increase flares and increase pain. There's still research being done on whether the contraceptive pill improves this or makes it worse, but the jury is certainly out on that. We just don't know. And really, people have to do a bit of trial and error to see what works best for them. So how do you manage? So if you know that your symptoms, if you are a woman getting your period and you know that the symptoms are getting worse around the time of your period, how are you going to manage that? So stick to the treatment regime. Make sure you are taking your medications as you normally would. Don't miss them, particularly around that time. Anti-inflammatories are really good for helping the increased generalized pain that people get around the time of their periods. If they're safe and if they're suitable for you, it's certainly a really good idea to be taking them just before your period or at the beginning of the period if you're getting that type of pain. Track your symptoms, know your cycle, know what to expect, know which days are going to be a little bit harder for you. Make sure that you do some gentle exercise over that time. You may not be able to go hard with your exercise at a time when at the beginning of your period where you've got a lot of pain. Give yourself a break. Know that this is a difficult few days for you or week for you during your cycle, and just allow yourself to maybe, relax a little bit. Just take it a bit more gently. If you feel comfortable, if anyone's in this, position where they do get worse around the time of their period, please, share your experiences. I know that not everyone would want to, but if you can, get into that chat box and let us know what works for you. Let's talk about family planning. So in most cases, men and women with rheumatic disease can have a safe and healthy pregnancy. So that's a big picture. But we do try and make sure that pregnancies are well planned. There are certainly some drugs that some of you might be on that would be dangerous in a pregnancy. And we want to make sure that at the time when you're planning a pregnancy that you're on the right medications. We really want to make sure that your disease is well controlled before pregnancy. And so that's including autoimmune diseases, but also people that have mainly a pain syndrome. It's important to make sure that things are settled and well controlled, if possible, before getting pregnant. We may need to transition to drugs that we know are safe in pregnancy. Contraception is really important with a lot of our medications, and we will always mention it. So if we put, for example, a woman of childbearing years on methotrexate, we'll always mention contraception, but then we might forget about it later on. And so I'm going to say, don't wing it. Really make sure if you're on a medication like methotrexate that is dangerous to a pregnancy, make sure you've got adequate contraception. And that's all the way through, not just when you first go on the drug. It's really worth discussing your contraception with your rheumatologist. And of course, with your GP as well. It's a really important part of it because unwanted pregnancies on some of our medications can be really, really challenging. Let's get on to pregnancy. So opposite end of the spectrum to contraception, we're now moving on to what do you do? What do you do when you do want to get pregnant, but this is what I hear all the time. I want to get pregnant, I am pregnant, but I don't want to take any medications when I'm pregnant. Can't I stop my medications? And I totally understand that, because the last thing any of us want when we're pregnant is to be taking medications. Sorry, I'm getting all these pop-ups the whole time. So no one wants to take medications when they're pregnant. We all feel a guilt when, you know, parental guilt starts very early on, and it starts before we even get pregnant. And none of us want to, particularly with a first pregnancy, nobody wants to be on medications. However, I want you to consider some of the things I'm going to talk about. Let's talk about the effects of the condition, whatever condition you have, on fertility and pregnancy. So we know that active rheumatoid arthritis, and more than rheumatoid arthritis, psoriatic arthritis, any type of inflammatory arthritis, when it is active, it can affect fertility, it can reduce fertility, and it can affect a pregnancy. The way that I think about it is that an inflamed body is not really a friendly environment for a pregnancy. So we know now, looking at long-term data, that women with rheumatoid arthritis used to have less children. We call that subfertility. So not that they're infertile, but they're just having less babies. Now we know that if we can get your disease well controlled, fertility should be normal. So that's really important to understand. So if you're going to stop your medications before you get pregnant, your disease is likely to, you're likely to lose control of your disease, and that can then affect fertility. So we usually continue safe medications when a woman is trying to conceive. Obviously, you need to discuss that with your team. And luckily at the moment, we know a lot about these medications. We know what's safe, and we can feel really confident about making sure you're on the right drugs. We always have to balance the risk of active disease, whatever disease you have, and active disease, not just fertility, but issues around preterm birth, joint damage, postpartum flare, versus, on the other hand, the risk of medications. We have good and safe drugs to use in pregnancy and breastfeeding. Please speak to us about it. If you just want to dabble and start to talk to someone about your medications, and you may not have a chance to see your rheumatologist straight away, please ring MotherSafe. Even if it's small issues like, for example, you might be pregnant and not quite sure what anti-inflammatory to take, or whether you should be on an anti-inflammatory, you may not be able to get in touch with your GP or rheumatologist. Ring MotherSafe. This is what they do. This is their job, and they're really, really good at counselling about medications in pregnancy. And then people say to me, but I heard that rheumatoid arthritis and other forms of inflammatory arthritis, they tend to settle in pregnancy. And that is true for some people. So about half of patients with rheumatoid arthritis will settle during pregnancy, but that means half won't. If you stop drugs before you're pregnant, how long are you going to be off those drugs for? If you stop drugs before, for any condition, sorry about this. How long is it going to take? It can take a long time. So we also know that postpartum flares in women that have inflammatory arthritis are very common. So we really want to make sure that there's some control in the pregnancy so that afterwards you don't get a flare. There's less data for psoriatic arthritis, but it's probably about similar. So probably about 60% of people improve and about 40% don't. In terms of people who have chronic pain, that's variable. And unfortunately, this is one area we don't have a lot of data, but we know that some women feel really good when they have chronic pain when they're pregnant. They actually feel better, but a lot of people will have more pain. It's going to be very variable, and I can't really give you any specific advice about that because I don't think it's very predictable. for all women, whatever your condition is, keep active. Special prenatal classes, all working one-on-one with your EP or physio is really, really important. How about coping with young children? Because this is the next step. So people that have children, you know, some women will choose to breastfeed. We've got many safe medications, and this is, again, something that you'll always check. But if you are breastfeeding and even bottle feeding, and even if you're a dad with rheumatoid arthritis or another form of inflammatory arthritis, you're going to be waking at night, you're going to be tired. It's a tricky part of life. There's enormous physical and mental stress having young children. We also know that women do tend to get increased pain and flares in the postpartum period. I'd love to hear from people who have been through this, and it often goes on for years and years. What have your experiences been? How have you coped with this time? Now we move on to the next phase. Some of you have been through this. Some of you are yet to go through it. Some of you will never go through it. But you know, we know that for some women, for many women, menopause is a tricky time, even if you don't have an underlying illness. But studies have shown that women with rheumatoid arthritis will experience shifts in their disease when their hormone levels change. We know that happens during menopause because estrogen levels fall. Rheumatoid arthritis symptoms can get worse. We also know that when your estrogen is reduced, and this is true of a lot of women, you can get sleep disturbance, mood changes, hot flushes. Add that to having a condition like, I'm saying rheumatoid arthritis, but obviously all the rheumatic conditions that we're talking about. You add menopausal symptoms to the symptoms of your usual condition, particularly if that condition is going to get worse. This can be a really challenging time. I wish that I had an answer for this, right? So I don't, and we don't have there is not a lot of good data and research about how to manage this time. Certainly, you know, the GP is your port of call in terms of making sure that you are on, if you need to be on hormonal treatment, are you on the correct hormonal treatment? Can you even go on hormonal treatment? Anecdotally, women report that staying really active during this period, as hard as it is really, really important. And people that have, you know, I've got a lot of patients who have used that time of going through perimenopause to really start being far more active, and have found that their symptoms are much more tolerable. Other people report that making dietary changes, for example, reducing processed food and sugars, can be really helpful for those symptoms. We don't have any scientific data about that. You know, I'm not going to pretend to you that that there are big trials comparing, you know, dietary interventions for people with rheumatoid arthritis or other rheumatic disease during menopause. We don't have it. It doesn't exist. So really, we need to ask other people who've gone through it what has worked for them. Sarah, are there any questions at this point, or any?
Yeah, there's definitely a couple, I think, good chance to ask. And
yeah.
There's been some people who have shared, the condition that they have and asking for advice from the rest of the people in attendance. So I think if you haven't had a chance yet, please look at the chat. You might be someone that can, help reassure or help someone else who's in a similar situation. But one question, Ilana, do you have any evidence, or have you heard much about IVF and IVF being harder, or IVF being more likely to fail in people with rheumatoid arthritis, or some of the conditions that you see?
So, look, assisted reproduction is a whole topic in itself. And in fact, there have been some recent international guidelines about reproduction or reproductive issues in rheumatology, and there are pages and pages on reproductive technology and how they kind of interact with our kind of conditions. It's going to be very individual whether your condition will have any impact on your chance of IVF. There's certainly no blanket statement. It is very likely, we think it is very likely that if you have very active inflammation, that is going to affect the success of IVF in the same way that it's going to affect the success of natural conception. We do have a lot of patients who do require assisted reproduction, but I certainly wouldn't want to give any individual, it depends very much on the condition, the activity of the condition, the other medications that you're on. But IVF specialists or fertility specialists should be really well aware of the underlying condition. Certainly having an autoimmune disease, if that is what is going on, can affect fertility, and the IVF specialist often will really focus on the immunological side of conception with those patients.
Cool. Awesome. Thanks for that. And then still on pregnancy a little, and you touched on this, and although you said it's individual, but Tanya shared that she's heard that people with AS during pregnancy, again, their symptoms might improve. And you mentioned that can be the case for other conditions as well. Could you just summarize again why that's the case, or if you've got a nice 1 minute answer for why?
We don't, so why do symptoms improve in pregnancy? I don't think we entirely know. Certainly there are hormonal changes. There's also a lot of immunological changes that happen in pregnancy because, your body has to work at not rejecting this growing fetus inside you, this fetus that's kind of a foreign body. So our immune system changes so that you accept this new foreign body that's growing inside you. So there are all these changes that occur, plus hormonal changes. So it's much more complex than that, but that's the broad reasons why there are changes in pregnancy.
Cool. And maybe just one more question. So women that have an inflammatory arthritis, are they at high risk of having lower bone density after menopause compared to people that say don't have an inflammatory condition?
Yes, and I am actually going to get to that.
Okay. Good segue.
It's a good segue. Oh no. Maybe I didn't. Maybe I forgot to put this in, and it was important. So it may come up later, but I'll address it now in case I forgot later on. So absolutely. So osteoporosis, really important aspect of post-menopause. And so that's true for all women, that we lose bone mass as after menopause because of the loss of estrogen. We also know that people with inflammatory arthritis have certainly an increased risk of osteoporosis. And women, when they're, pre-menopause, will have, if they have active ongoing inflammation, will have faster bone loss. So women are far more likely if they've had and men as well. So men also are at risk of osteoporosis with inflammatory arthritis. For women, that increased risk really, hits us hard around menopause because of the natural loss of estrogen. So really important that we manage our bone density well prior to menopause. It's something for prevention. We really, and particularly the patients who have an inflammatory arthritis, we really want to manage that as early as possible. So we want to make sure that you're having adequate calcium, adequate vitamin D, that you're doing good resistance exercises so that you don't get to the point where you hit menopause and you start to be at risk of fractures. So that's kind of a preventative thing that really should start early on.
Beautiful. Okay, you're good.
Right.
Yes, I
good.
think it's happening, which is nice. So keep that going, but you're all good.
All right. Let's talk a bit about intimacy. This is what people say to me. I say, no one ever talks to me. As patients have said this to me. no one ever talks to me about this. And this is like the hardest thing, for some people, that they've really had a significant impact on their sex life. We don't talk about it, I mean, we should, but we don't. And there's a whole lot of reasons why that happens. And again, there'll be some men watching this, and it's true for them as well, right? So, but we're talking about women today. So, firstly, having chronic pain and chronic fatigue obviously can dampen desire. That goes without saying, right? If anybody is watching this and suffers from this, you all know that I'm not telling you anything you don't know. Some autoimmune disorders decrease lubrication for women, and that can make intercourse really uncomfortable. And that's common in Sjogren's syndrome. It's supposed to say RA, rheumatoid arthritis, lupus. Because of dryness, we see women having an increased risk of urinary tract infections, particularly when they're sexually active. And I'm going to say that this symptom is just important. So if you're someone who suffers dryness, it's just as important to discuss with your doctors as your dry mouth and your dry eyes. This is an important, and we have treatment and you can be helped. All right. Make sure that if you're in this situation, that you use an over-the-counter treatment like Replens, that you're using adequate lubrication if you are sexually active. And please discuss it with your GP. You can certainly discuss it with your rheumatologist as well. Menopause itself can also lead to these symptoms. So we're kind of talking about additive issues that can affect intimacy. Here are some really good resources for men and for women. So if you Google creaky joints and sex, endless resources for you, okay? From these issues that I've discussed to more comfortable positions during sex, etc. It's all there, right? So we don't need to talk about it tonight, but please use that as a resource. I was quite amazed when I did a bit of Googling and I thought, yeah, there's a lot of information here for people that are looking. It's all there, okay?
So there you have it. That's part 1 of Rheumatology and Women's Health. If you'd like to finish off the presentation, you can access the rest of the talk on BJC Connect. You can create an account anytime. It's free. And that's where you can access not only this presentation, but a number of other live events that might help you live and feel that little bit better. But otherwise, hope you enjoyed it and look forward to seeing you on our platform soon.